And thank you very much to our generous sponsors of the Wisconsin Health News panel series. These important and valuable discussions would not be possible without their support. So a huge thank you to AARP Wisconsin, Ascension Wisconsin, Advocate Aurora Health, Group Health Cooperative of South Central Wisconsin, Hush Blackwell, Marshfield Clinic Health System, Wisconsin Medical Society, and WPS Health Insurance. Wisconsin Health News is a nonpartisan, independent online news service. In addition to hosting events like these, we also publish a daily email newsletter. If you're not yet a subscriber, I encourage you to sign up for a free trial. You can do so by signing up through the event evaluation form, which we'll email out after today's event, or you can also sign up on our website at wisconsinhealthnews.com. An extra thanks today to WPS Health Insurance, today's featured sponsor. We are very grateful for all of their generous support. And here to say a few words is Thomas Spelsberg, Vice President of Medicare Market Solutions.
Excellent. Thank you, Tim. Good morning to everyone. As Tim said, my name is Thomas Spelsberg, and I'm the Vice President of Medicare Market Solutions for WPS. And that's one of our lines of business that focuses on health insurance for seniors. More specifically, the main service is a Medicare supplement health insurance for retired seniors. It works in conjunction with Medicare. It can cover all the healthcare costs that Medicare doesn't cover. WPS is proud to be a sponsor of today's Wisconsin Health News panel discussion. So thank you again for having us. Just give you a little bit of background about WPS. We were founded in 1946 to help veterans returning from World War II afford healthcare. Over the years, our services have grown to reach individuals and families across Wisconsin, seniors across the country, and a really active duty and retired military personnel around the world. So if you did the quick math there, this is actually our 75-year anniversary. So we're pretty excited about that, celebrating that. Transparency in healthcare, it's a great topic for this group due to how important it is for consumers and from my perspective, the related positive impact it could have on the healthcare community industry. Thinking about the type of transparency that we're talking about here, it falls into kind of healthcare systems quality and efficiency, which I think about just the data related to quality and price, but also the customer care experience. And one thing that I'll be watching is just to see as this continues to unfold is how easily is the information able to be accessed, right? Because it's one thing to make it available, but it's another to make it it's another thing if it isn't readily available to be used. I can tell you at WPS, we're excited about that things are moving in that direction. We're always looking for ways to make healthcare easier for the people we serve. In my case, it's all about the senior customer I mentioned earlier. And I can think of a related example for me around Medicare coverage. So Medicare coverage is very confusing. It can be very complex. We work very hard to educate people, give them the information they need up front, how it all works, what their options are. And so that they can really make the best decisions for their needs, which I think is really sort of what the transparency around the healthcare information is really trying to get at here. And then kind of ongoing, we do a lot of work to ensure our members have all the information they need to help them understand, specifically how their health plan works once they've started using the benefits. So that's all I have. I just want to say thank you again and looking forward to today's panel discussion. Tim, I'll turn it back over to you. Thank you.
Great. Thank you so much, Thomas. And thanks again to WPS for all of your great support. So today's event is as talked about, focused on healthcare transparency. Prices for common procedures vary widely from health system to health system, and sometimes even from hospital to hospital within the same system. At the same time, finding that information can be difficult. Businesses and other purchasers are increasingly calling for that data from hospitals and insurance companies to be more public and accessible. Boosting transparency, they say, will increase competition and drive down the cost of healthcare. But how much these changes will impact patient decisions and spending remains to be seen. So we're hoping to get a clearer picture of healthcare transparency today, and we've lined up an all-star panel of experts to try to do that. So I want to dive right into the questions, and I'd love to hear from each panelist on this first question. Healthcare transparency can mean different things to different groups. So Dr. Bartholow, let's start with you. In a sentence or two, what does healthcare transparency mean to you? I mean, what do you think should be the goal of healthcare transparency?
Healthcare transparency, in my mind, needs to make better care. And at the end of the day, being able to be transparent to the doctor, to the hospital system, to the employer, to the member, frankly, the customer, all of that very important.
Great, thank you. Brian Stevens, what do you think? Well, what does healthcare transparency mean to you?
Well, I've been at Door County Medical Center since 2005, and we implemented our first patient estimates in 2006. So we've been working on that for a long time, and really trying to hone that information and give patients what they need when they're shopping around for services, and when they're just looking at different options that their physicians might be providing them. So to me, it's really about providing our patients with the information that they need at the time that they need it, whether that's price, quality, better descriptions, whatever they need.
Thanks. Dana, what do you think? What does healthcare transparency mean to you?
Well, the wheel's role in the healthcare ecosystem is a little bit different. Our role is really to provide unbiased information to everyone. So from my perspective, we'll have transparency when all stakeholders, whether you're a payer or a consumer or a provider, government entity, when everybody has access to the information they need, knowing that everybody's information needs are a little bit different.
Great. Cheryl, what do you think should be the goal of healthcare transparency?
I'm off mute. From the standpoint of employers and consumers, transparency for us means having information that we can understand and use to compare the price and the quality of care so that we can make more informed decisions. And for us, transparency is really the cornerstone. It's the starting point to make a free market healthcare system work.
Great. And Brian Potter, last but not least, what do you think?
Again, agree with everyone else. I think maybe an underappreciated part of transparency is there's data and all those things, but there's the communication challenge in healthcare. And so it's not only having the data, but how you use it and how you package it in a consumable way to the audience you're intending it for. Because, we have the challenges of, healthcare has insurance lingo, we're basically a third-party payer system. We have the clinical lingo, and all of those things are, oftentimes complex. And so to actually take that information and put it into usable formats for the intended audience, and oftentimes that's the patient, is a challenge. And we always have to remind ourselves of that, because sometimes those of us that are closest to it use all these, jargon terms and things like that. And so that's a real big challenge. And so having all the data in the world gets you part of the way, but then actually breaking it down into usable pieces is a big challenge. And that's a big part of transparency.
Great. Well, thank you, Brian. So I'm hearing some good similarities, some good agreement, and maybe some differences, some unique perspectives on this. So I want to talk, as we get started, about some of the transparency efforts already underway. Brian Potter, let's stick with you. Can you tell us briefly about WHA's price point? What does that do?
Right. So we've actually had, through our information center, we've had a price transparency and a quality transparency website for over 15 years. So basically a year after we started collecting hospital claims data, we put out our first price transparency website. So and so the perspective of that has really evolved. First, and so kind of backing up what I just said before, we had all of this data. And so when you're going to put that on a price comparable website, how do you take all of these millions of claims and break it down into something you can search and understand? And so, basically the decisions we had to make were, how do you group this data? So on the inpatient side, that was actually basically pretty easy, because DRGs are sort of the accepted way to group this into a thing that's understandable. On the outpatient side, it gets even more complicated, because there's things like outpatient surgeries, which tend to be grouped more on like principal procedure type things. And I'm sorry, I apologize for getting into the weeds a little bit, but I mean, there's complexities to all this. And so other outpatient things like ER visits might be on diagnosis categories, because you typically present to the ER with, let's say, stomach pain. So you might want to search on that. And then there's all the other outpatient type information, which we decided to group using EAPGs, which is a grouper methodology that Medicaid actually pays on. So there's a lot of complexities around the data, getting it into these searchable things. Then throughout time, once we sort of, accomplished all of that technical piece, price point has evolved, because price shopping is one piece of it. But as I mentioned, we have a third-party payer system. So really, even before you get to that level, you have to understand, most people have health insurance. You have to understand what your plan is, whether it be you purchased it on the exchange, whether you are operating under what your employer provided, whether you're part of an entitlement program, Medicare or Medicaid, you need to understand, what the benefits are, what the coverages are, what are your out-of-pocket expectations, co-insurances, deductibles, all that lingo that needs to be defined. And then who's in your network. To just go blindly shop before you even know who's in your network is actually not a good way to go about it. So price point has evolved to the point where we ask those types of questions up front. And then for those that don't have insurance, in this day and age, we provide links to Medicaid and to healthcare.gov because one of the other things about communication and transparency is we have between 70 and 80,000 people in Wisconsin that are eligible for Medicaid that aren't enrolled. And so before you even start price shopping, you should see if you're eligible for some coverage. And so, and then even if you're uninsured after all of that, I think you'd want to look at your hospital's financial assistance policy. So we provide a link to that. Then you get to the actual comparing charges. And then after that, because as part of these rules, we're getting to things like negotiated discounts. We actually incorporated the fiscal survey that we collect every year to provide, at least at a high level, each hospital's average percentage of charges collected from a commercial perspective from Medicare and Medicaid. So we're really trying to encompass all of those different pieces that a consumer or a patient might need. And then from there, we actually, if you're looking at a certain provider, we provide a link to our Checkpoint website, which has all of their quality scores. So we've really tried to take a global look at from a statewide website where you can go one place and compare versus some of these rules where people are putting it in their own websites and you have to go search around. The concept around price point is really about putting as much information that we have and make it available in as consumer friendly of a way in one place.
Well, thank you, Brian. I appreciate the great description. So as you described, WHA's price point has certainly evolved over the last decade and a half as it's been in existence and has a lot more complexity to it than when it started. I think you even mentioned on the frequently asked question page of price point, though, that it's still not a truly accurate description of if you're a patient and you want to go get a knee surgery at Door County. It's not providing that type of information. I guess, could you just, and correct me if I'm wrong, and I guess, talk a little bit more about the value that this provides for a patient looking to shop services between hospital to hospital.
Right. So no, I would say it is accurate. It provides basically an average charge for Door County for the thing you look up. Now, again, getting into what your plan's negotiated rate might be. I mean, again, Door County might have some information on that. Your insurance plan should have more information on that. But again, we try to provide some perspective in terms of that sort of average percentage of charges collected on the commercial side to give you a rough idea of what you might expect from a discount. We also, again, link, like I mentioned, to the hospital's financial assistance policy, which would also give you insight as to the kind of discounts that might be available. So it's not inaccurate. It's basically using all of the data we have from a statewide level through our data collection. And we use basically every piece of information we have to put on a statewide website, which, there's a lot of advantages to that versus, again, going around and finding, files that are located on all these different websites. So again, we've maximized sort of all of the information that we have and tried to make it as consumer friendly as possible.
Great. Brian Stevens, one of the main drivers of transparency is frustration by patients and purchasers that a knee replacement can cost, let's say $25,000 at Door County Medical Center and then $75,000 at Bellin. And I'm obviously just completely making these numbers up. But why do procedures vary so widely from hospital to hospital and sometimes even within a single health system?
Yeah, I think a lot of it has to do with which bundle are you looking at, and that's part of the discussion we were just having about the Wisconsin Hospital Association's price point website too. Brian and his team do a great job of pulling together as much information as they can, but they still don't always know, what the radiologist charge is going to be associated with those visits, or, maybe what the physical therapy charges are going to be associated with the knee replacement or something like that. At our hospital, we really do try to aggregate as much of that as possible. And, we try to list out on our estimates exactly what's included or what components are included, but ultimately we're giving you a total price for a complete episode of care. And I think that's part of why you see a large discrepancy from one hospital provider to another is that, sometimes they're giving you everything from the pre-op visits all the way through the therapy, and other times they're giving you just what's going to happen for those couple of days in the hospital. So that's part of it. The other part of it is it has to do with health insurance contracting, and there's still just a number of different ways that we can contract with health insurance companies for procedures, and it kind of falls along the same lines. Sometimes it's a bundle and it includes all those components, and other times it's very specific to each component and each procedure that's done. And so we may reflect an estimate a little bit differently than how Bellin would based on our contracts for that specific payer, looking different than what Bellin contracts look for them. So it is complex, and that's really the reason that we feel like from a price transparency standpoint, we need to provide different options to our patients. So yes, we have the online price estimator that we've been really trying to improve upon over the years, and feel really confident about the estimates we're able to give out through that. We've also, as we've evolved over the years, we've started to produce more estimates up front, where as soon as our physicians are ordering something, we're giving those estimates out proactively to our patients. But I think that it is very complex, and sometimes patients just need to sit down and talk to someone. And so sometimes the best option is still sit down with a financial counselor. Let's talk through it to make sure you understand exactly what you're going to see on a patient estimate and what your options are in terms of payment arrangements or financial assistance or whatever the case may be. It's still pretty hard to shop around online for everything, just because everybody's situation is different, and we think a lot of times still a face-to-face conversation is going to really be most helpful for our patients.
Great. Dana, can you briefly tell us what WEO does? Maybe specifically tell us more about your all-payer claims database.
Certainly. So WEO is the state's all-payer claims database, which means that we bring in information from all different types of payers. So Medicaid, Medicare, Medicare Advantage, self-funded, and commercial payers all contribute their data to WEO. And right now we have close to 80% of the state's population in our database. What that means is that we can take that information, which really covers the entire continuum of healthcare. We're not limited to inpatient or ambulatory surgery. We can take all of the information and we can create bundles and episodes of care that are standardized across different healthcare organizations. So we create that type of information. We provide de-identified data files to a variety of different organizations. They use the information in many ways to look at quality, to look at differences in pricing, to look at how to create networks. We can look at access to care. We can look at social determinants of care. We also do provide some predefined reports, and we do custom reporting for various organizations as well. So our role in the ecosystem here is really to provide information, and to provide information in an objective way to really help drive decisions in healthcare.
And so 80% is a great percentage of the state. Who is this 20% that you're missing?
Yeah, we're missing the uninsured, because of course we're collecting fully adjudicated claims. We are missing some of the self-funded employer groups. We're working with them to try and bring that information in the next couple of years. And then there are a couple of health plans that do not contribute. The vast majority are, great contributors to WEO, but there are a few who choose not to. We are a voluntary contribution system, and so we do rely on, the goodwill, and we rely on our data contributors to really think of the greater good and want to work to improve healthcare in Wisconsin.
Great. Cheryl, can you tell us about some of the transparency efforts that the Alliance is involved in, including Quality Path and the RAND Corporation's Hospital Price Transparency Project that you guys have been involved in partnering with or working with?
Sure. Yeah. Since the founding of the Alliance 30 years ago, we have been committed to giving employers and consumers information that they can use to make important decisions about healthcare. And, we have come at this from a number of different perspectives, working with the providers who are part of our provider network to share information with consumers on the price and the quality. And through the RAND study that you just mentioned, Tim, where self-funded employers from across the country are contributing data, along with data from all payer claims databases and some insurance companies to send the data to RAND, where they calculate the prices that we're paying compared to Medicare. So we're able to see state by state, hospital by hospital, what we're paying as a percent of Medicare, and it's revealing. I think in Wisconsin, we're at, in the aggregate, about 290% of Medicare, which from our perspective seems far too high.
Great. Dr. Bartholow, what is WEA Trust and Health Tradition Health Plan doing around transparency?
We deeply use WHEEL to begin with as a comprehensive database. You're right, Tim, there's 20% missing, but frankly, no more comprehensive database available. Very proud of the all payer claims database in the state. The other thing that we spent a lot of time on, and our conversation is focused much on price transparency, but we have spent a good deal of time around safety transparency. Why is it that, we, for instance, have infection rates that vary, and how can we support teams to actually bring those infection rates down? Folks in the audience will be aware that, say, a hip or a knee replacement will be a $20,000 event, but a hip or knee replacement with an infection is about a $120,000 event. WEO has shown us also that in various places you could get a delivery for one amount of resource use, but across the state you can also get that delivery for as much as 80% more, if not 100% more resource use. And we figure that once you have a healthy mom or healthy baby, then extra resource use is actually just potential harm. So we've used it in that way in order to try to identify how can we achieve an excellent result by using the fewest resources and sort of invading the body as least necessary.
Great. So all the panelists have talked about a great number of things going on around transparency. It's a big list. We're obviously missing a lot that's happening in the state. Dr. Bartholow, are you concerned that we have too many transparency initiatives happening all at once? I mean, should there be more standards, uniformity on how information like this is reported and displayed?
Calling back to Brian's comment on how you present this data, right? I think that it's key important that we find ways to have our care teams in particular, the doctors, yes, and pharmacists, nurses, therapists actually understand how it is that that data can be used. Do we have too many? Please, over this next 5 years and such, I hope that we will emerge with our various rich databases, the opportunity for us to understand how we arrive at safer care more quickly. But I don't think we have too much at all. I realize it can be confusing, but I think we ought to lean into it. And instead of being afraid of transparency, we ought to use it for better care.
Great. So another effort underway is a rule put in place by the U.S. Department of Health and Human Services requiring as of January 1st that hospitals post standard charges for all items and services for 300 of their, quote, most shoppable services in a consumer-friendly format. Brian Potter, can you briefly explain what this rule is and how it's different than for example, price point?
Well, the shoppable services or sort of a online price quote, there's an alternative to that. But, I think it's actually kind of consistent in a lot of ways with price point because it's talking about shoppable services, which are sort of grouped services, which is, again, how we decided to put price point out, again, 15 years ago. So I think that part of the price transparency rule makes quite a bit of sense. it's really it's that charge master piece, I think, that we have more of a problem with, given how, contracts work and how, even Medicare and Medicaid don't reimburse that way. They reimburse on these groups. So the shoppable services component of the rule, and WHA's had a price transparency task force for over a decade as well. And so again, I think, like Brian mentioned, he's been compliant with that way before this rule ever came out. So again, we think that's the way back to that whole, how do you communicate these things? The shoppable services component is the part of the rule that we think makes the most sense.
So can you expound on that a little bit more? So hospitals overall don't like this rule. The American Hospital Association sued the Trump administration to halt this and is lobbying the Biden administration to reverse it. Can you talk about just a little bit more hospitals' concern with this rule?
Yeah, and I would say it's not just the provider community, it's the insurance community, it's also the U.S. Chamber of Commerce, the Federal Trade Commission. Again, so there's some issues along with this. Again, we tended to focus more on how do you even comply, again, with this all charge master things and negotiated rates, because what you're trying to do is convert contracts that aren't necessarily charge based and allocate that reimbursement to charges, which again, we've had Epic come to several of our transparency meetings and they were struggling on how to do this. So the rule was clumsily done, I think, in that way. That's, basically doing it at that level is almost assuming that you go back to how healthcare was paid for 30 years ago. The ironic part about of getting to that level is that CMS regulates Medicare and Medicaid. Neither of those programs pay charge-based services at all. They pay on DRGs and APCs on Medicare. I'm sorry about some of the weed stuff, but Medicaid pays on DRGs and EAPGs. So it's grouped. It's more at that shoppable services level. So how do you take contracts that are per diems or are capitation arrangements, and how do you, and again, we have a lot of those kinds of contracts in our state. How do you translate those then into this thousands of line item things? The guidance on it was terrible. Medicare and Medicaid don't have to follow it because there's the provider rule and then there's the payer rule, and they're sort of in parallel tracks. So there's just a lot of problems with that. And so as people are looking for these files, they're saying, well, these aren't comparable at all. Well, again, I think most people have said that they weren't going to be comparable, because to compare a contract that's a per diem against a contract that's a capitated arrangement and trying to allocate that to thousands of charges, it's clumsy on that way. So again, we think the way to do this is sort of the way we've determined through price point is you do it on a service level. And so that shoppable services thing, and that's how price quotes are generally provided as well. That's really the direction to go. So that's the part of the rule we think makes a lot more sense and could be built upon.
So nationwide, there were a number of hospitals who weren't complying with this rule. How prevalent is that in Wisconsin, and why is that? Why are some hospitals not complying with this?
Brian, do you mind if I speak to that a little bit?
Sure.
I just jump in just to speak kind of on behalf of one of the member hospitals of Wisconsin Hospital Association, just to say Wisconsin Hospital Association has been very proactive about this. And I've had the privilege of serving as the chair of our price transparency task force over the last several years. And so one of the things we did, long before this rule was final, was to try to understand what kind of direction we needed to give Wisconsin hospitals to help them comply with this. So we've been meeting on that for a couple of years, and we're able to publish a document that went out to revenue cycle leaders at all Wisconsin hospitals to help them understand the best ways to comply with the law. So, again, I just want to point out that Wisconsin hospitals are committed to transparency. Probably in a way, when I moved here in 2005 from Tennessee, I'd been involved in Tennessee in the patient-friendly billing exercise that HFMA had put on. And when I moved here, I was just amazed at how much further ahead Wisconsin hospitals were than we were in Tennessee with respect to quality reporting and price reporting and those sorts of things as well. So anyway, just to say every Wisconsin hospital has been thinking about how to comply with this for a couple of years, and had some really good guidance from the Hospital Association on the best way to do that.
Well, can you talk a little bit, Brian, about what it takes for your hospital to comply with this specific HHS rule, and just your thoughts on the number of transparency initiatives that are out there.
Yeah, I think, and I'm glad you asked that. That has been a challenge, and that's been the part of this rule that we've been uncomfortable with. Is, we've had price estimates, as I said, since 2006 available to our patients. We believe that that's kind of the value-added step to comply with this rule and to put out the charge master file that updates based on, whenever our contracts change and those sorts of things. It costs us about $6,000 in consulting fees, and, we're a small hospital compared to most in the state. And the dedication of a lot of hours of our PFS, that's Patient Financial Services Director as well. So there was certainly an expense involved in us complying with this. And on the flip side, we don't see any additional value in that charge master file to the patients. I'm not aware of a single patient who's gone out and used that file and asked us questions about it or anything like that. I think that file that we have to put out there to comply is more something that's being used within the industry than it is by our patients. So we just don't see a huge value in it.
And do you think that's in part because, there have been reports nationally that sometimes this file isn't readily available on websites, some systems even, have been accused of burying it, so it's almost impossible to find. Is that in part why there hasn't been as much use of it, or is it just because, in your opinion, it's just not valuable information for patients?
I just think the example that I've used before is when I go to Culver's and I look at the menu, I don't see how much a pickle costs and a tomato costs and a slice of cheese costs and all of those sorts of things. And that's what the directive from DHS is. That's the level of detail we need to put out on our website. A patient wants to know the price of the hamburger, and that's what we've been trying to provide for years, is the price of that hamburger, so that they can understand really what it's going to cost them.
So for the most part, if you go to a Culver's in Milwaukee and you go to a Culver's in Eagle River, the price for that hamburger is going to be pretty much the same. And it's going to be the same or similar if you go to Tennessee or you go to Illinois. So would it be easier if we just had a kind of a uniform price for hospital procedures, that are paid by private plans or self-funded plans? If a knee surgery is going to cost about X amount of dollars if you're at Door County or Ascension, would that be something you'd support? Wouldn't that kind of advance us a lot in terms of this complexity and confusion?
Well, it sounds good, but it depends on how committed you are to having services available in communities throughout the state. I can tell you up here at Sturgeon Bay, where our main hospital is, we're halfway up the Door County Peninsula. And so it's critical that we have services available like, MRIs and CAT scans and sophisticated lab equipment. And the reality is we pay the same for those pieces of equipment, sometimes more, because we're a small facility, than a larger facility down in Green Bay or Milwaukee would pay for that equipment. And they're running much more volume through that equipment. So, just by the nature of that, it's going to cost us more to provide some of those services than it will cost a facility in an urban setting. So, if you're committed to providing those services to folks who live here on the peninsula, and I would argue that it's critically important that we do so, there's going to be a different price point at times.
Great. Thanks, Brian. Cheryl, let's move on to you. What type of impact do you think this HHS rule will have? How useful do you think this information is, and also how do you think it can be built upon?
Well, I think it's a good step in the right direction. I think it will take a while to mature, and it will be helped along with clearer guidance and also stronger penalties for non-compliance. I've been listening to the conversation and I hear all of the talk about how complex this is. And my thought is, it really doesn't have to be this complex. It can be simpler. There are providers in the market that are stepping up to make healthcare high quality and simpler, and are selling us the kind of care we want to buy, which, as Brian pointed out, is a bundled procedure, so we know exactly what it's going to cost at a fair price. Some delivery systems are doing that. A lot of innovative providers who are outside of delivery systems are doing that on a cash basis. Case in point, I just got off the phone with one of our employers in the Wausau market who talked about the fact that they are being charged $60,000 to $80,000 for hip and knee replacements in that market, and they've started sending their employees to Oklahoma, where they can get the same care for $15,499. It can be simpler, and people are using alternatives to say, none of the above.
Cheryl, what do you think about Brian's point that as we move more towards bundled payments, how valuable are some of these price transparency initiatives that are out there right now that detail different parts of, in his analogy, the cheeseburger. If we are moving towards bundled payments and we want to know how much a bundled payment costs, does it matter how much the different parts of that bundle costs?
Let's figure it out. Let's just look at this from the standpoint of what employers and consumers need to know and make it simpler. Hospital prices have gone up 225% in the last 20 years, and hourly wages have gone up 80%. We can't afford to ignore this or do nothing. Healthcare debt is the #1 cause of personal bankruptcy. It's not something we can just say, we can't just be frustrated with the current situation. The cost of doing nothing is too high.
And what impact do you think more transparency could have on costs? How it is knowing more about how much different procedures cost? How will that help bring down these prices?
Well, in the early examples where price transparency has been more prevalent in parts of the country, the prices go down and they moderate. I don't know of any other industry where hiding prices is a helpful thing.
Thank you, Cheryl. Dr. Bartholow, what do you think about this HHS rule on transparency? What impact do you think this could have, and how do you think this information can be used?
Well, on the law, there's going to be parts of it we don't like. I think we can all be unified about that. There'll be parts of it, I think, that in its major thrust, though, that are trying to do the right thing. We need to find a way to identify how teams, and Brian alludes to this, Brian Stevens has talked a bit about the sort of the notion of a bundle of services to be available. We're watching some of our provider teams properly try to name a high quality knee, hip, even angioplasty delivery, right? Colonoscopy. They're trying to compose that by using the fewest number of resources. I think if we'll be patient with this law that will need to be calibrated, I think that if we lean into the CMS bundled pricing efforts, that we will find ourselves at some near future being able to have ever safer care, because it's been carefully studied, right? Which elements are actually necessary in order to make the most safe care. And frankly, safer care is almost always less expensive. That final thing, I'm going to add, I'm going to jump on to Cheryl's comment too. Look, Milliman will tell us that healthcare costs are going up at about 8%, or maybe some years it's 6%. But and that's not, we all share in the responsibility of how to control that here in the panel, and frankly, many in the audience. This isn't like insurers are going to fix this alone and such, right? But if the rate of increase is 8% for healthcare and wages are going up at 2%, every one of us can be sure that we are going to cause a problem for especially our vulnerable folks. And we've seen this particularly in COVID. We don't mean to manufacture poverty, right? But for those of you that are working around United Way units or other units of community awareness in the state, you're watching groups of people be much more at risk than they were before. And I think transparency needs to get about the task for all of us, right? Trying to find affordable care that, yes, indeed, is actually safer.
So the Trump administration, who put in place this rule at HHS, one of the reasons they move forward on these transparency efforts is with the belief that this would help lower costs. This hospital price transparency rule went in place on January 1st. Next year, a rule will be put in place that, as supporters say, will fill in the gaps, as it requires most health plans to disclose pricing and cost sharing information. AHIP, the National Trade Association for Health Insurers, opposes this plan, saying it will reduce competition and drive prices higher. Can you talk about that rule too? I mean, you're kind of arguing for more transparency, but health insurers are fighting against more transparency, saying it won't reduce costs. What's your stance on that from a health insurance standpoint?
We all love our national associations, right? It might be okay if we believe, though, here in Wisconsin, that the greater transparency through WCHQ or Wishen or WIO or Metastar or those various organizations, I believe if we are diligent with the use of the information, we'll find safer care. And as I say, I just don't see how, if we're truly all going to carry the rock of this big task up a hill towards safer care, I don't know how it's going to be more expensive. I encourage us in Wisconsin not to be afraid of this. Let's lean into it. Let's make it a Wisconsin idea that we're able to make transparency an element of how we did better.
So what more can health insurers do on this to advance this?
I think in particular, frankly, I think the use of WIO data to identify how much an episode of care costs, and then being able to feed that back properly to care teams so that they're aware. I mean, many in the audience may or may not know that many of the physicians couldn't tell you for the main things they do. Let's say it's a knee or a hip or an angioplasty or such. They may not know how their use of resources compares to the person that they're practicing next to, let alone the hospital or clinic across the state. And my plea to the state is lean into this use of resource analysis that's already been proven for a decade to be available through WIO, and lets us use that to make safer care.
And then what is?
Tim, I'd like to answer that question as well, even though the Alliance isn't an insurance company, but our employers are self-funded employers. I think our contribution is to use the data that's currently available to us to structure plan designs so that we are encouraging employees to go where care is good and costs are low. And even though the information today is maybe imperfect or incomplete, let's use what we've got. Let's share it, broadly with providers and consumers and work to improve it. And we've seen that pay dividends, not only in terms of better care and lower costs, but better information.
Dana, let's bring you in here. What impact do you think more transparency could have on healthcare costs?
Well, I think the federal government is really putting a lot of stake into this. And I think if we actually look at the numbers, it is working for them. So Medicare currently has only 10% of payment left in fee-for-service. They've invested a lot of money in transparency, but also in demonstration projects to figure out how different payment models can be used, what works, but also what doesn't work. When we look at the commercial side, about 55% of insurance is still in fee-for-service, and for Medicaid, it's even higher. It's at 68%. So whether we agree with the details of the rule or not, it is working for Medicaid to, push the envelope, and for the federal government to take the lead in pushing towards more transparency. Whether hospital transparency is really valuable or not, I'm not confident of that. And the reason I say that is because almost all hospitalizations are planned. And that means that there are costs that are incurred before the hospitalization. There are costs that are incurred after the hospitalization. That's really what this whole episode of care means, right? So how do you bundle all that together? Well, there are software programs out there that do that today. WEO uses episode treatment groups. They're risk adjusted. They provide a fair comparison across different providers. There will be additional advances in these types of analytics going forward. We're seeing it already. Where I see real advances coming out of what the new rules are on transparency is that health plans actually have to make their files available in what's called a machine readable format, which means organizations like data aggregators, software developers, and app developers will be able to access those files and create information using existing analytics and really deliver that information to consumers in a different way. You know, we in Wisconsin have done a phenomenal job of putting information out to the public through websites. But what we know 20 years later is that the majority of users of those websites are the providers themselves, and that's good. I mean, we've seen the improvement in quality that that has led to. But we also know that consumers don't go to a website in order to find it. So we need to get to the point, and I do believe these transparency rules will get us there, where you can pick up your cell phone and you can pick out an app and you can just get the information you want when you want it. Or when you're sitting in your doctor's office, you should be able to know what is the price of the different alternative treatment options that you have. That should be available to your doctor and you as you're making decisions at the point of care. I think it's going to be a while, but I think we're moving in the right direction.
So I just want to follow up on that. Yeah,
Could I just
sorry.
add to that?
Sure.
I'm grateful. I'm grateful for the work of Mark Scrimshire, various other folks that have been working on Blue Button Generator, the accelerator that we're privileged to have here in the state, as well as others. Had brought forward Anish Chopra not so long ago to talk about how it was that the startup community could actually work with others to make this data more available. I think it's going to be 5 years, kind of like the Apple App Store, but it's really important, and I'm grateful. We've seen them at medical society events talking about Blue Button already, and a variety of other places where it's important that the clinicians be thinking about how can I do better, right? It's not just the individual price of the pickle. I think that's a great analogy. It is, though, how can I make the safest complete whole without invading your body and having a complication, right, that we might be able to avoid.
And I'm going to ask Dana this, but Dr. Bartholow, while I have you briefly, I think kind of what Dana is saying that is so far consumer-friendly transparency efforts haven't really attracted most patients, and maybe in part that's because of the information available. Could you briefly expound on that as well? I mean, at this point, how interested are most patients in transparency? I think, as has been talked about, unless you have a health savings account or a high deductible plan, if you have private insurance, they're going to cover a good chunk of your service. So it doesn't really matter if the knee surgery costs more at Bellin or Door County. It's what your individual insurance company is going to cover. I mean, is that a fair assessment that at this point, a majority of patients aren't that interested in transparency?
Dana, can I? My response to that is, remember the opening of the internet when none of us wondered, am I really going to buy something online? Am I really going to take my credit card? And, there was a period of new interest that happened. And we wouldn't ask that question, today. I think if you look at, as a company, we have about 21 different school districts that have deductibles that are north of $10,000. And for those individuals, you bet they're shopping, right? They're asking us, well, how is it that I make, $35,000, $40,000, $50,000 a year and I can actually afford that? On the Medicare side, we know we've got about 53 or so million beneficiaries as a nation. And we've got about 10 million people signed up for Blue Button today. And I'm guessing that few of those people are using that technology. But I can't believe that the startup community is not going to leverage the opportunity of bringing transparency to folks who increasingly want to know.
Dana, what are your
Yeah,
thoughts on that? I mean, WEO has been involved in consumer-friendly price transparency efforts in the past. What are your thoughts?
Yeah, I actually believe consumers are interested. I don't believe that we've quite gotten to the point yet, although I think it's coming fairly soon, to where we can deliver the information that they want at the time that they want it through a method that works for them. We haven't quite gotten all of those pieces connected, but I do think it's coming. I think it's coming through the increased availability of the raw materials that will then be able to be transformed into these types of consumer applications. So I think it's coming. The thought that, well, I only have to pay a little bit, so I don't care. I'm not sure that's true. I think people care anyways. And I think when most people are able to recognize that if we all pay more, then prices continue to go up and we're all going to pay more. I mean, I think most people understand that. One of the interesting things that I've noticed over the last 20 years as I've been involved in this work is that we as a healthcare industry have not probably done the best job we can to help patients know how to use this information. So I think back to when in the late 90s, many employers moved from pension plans to, employer contribution plans or 401ks or whatever you have. And there was a huge education effort to help people understand the difference between a bond fund and a stock fund, that type of thing. Basic financial information most people didn't have. We've not done that yet in healthcare. We haven't actually said to people, here's how you should shop. So one of the interesting things, WEO did support a public reporting website for many years. We took it down a few years ago. But before we did that, we actually spent some time because we had partnered with some consumer groups here in Wisconsin who worked with individuals to help them learn how to use that information. We then supported some surveys of those individuals, and their response was they needed that educational support to know how to use it. But once they understood that, it was very helpful to them. So I think it's a matter of bringing together all of the components, the technology, as well as education to really help people be more savvy consumers.
Yeah, and I'd just like to jump in because that's what our website has evolved to provide, defined terms and across those things. So to be a resource, and I guess in responding to if this transparency rule is going to improve things, I think the industry is. Again, we've been heavily involved with Epic in our transparency task force, and their modules for providing estimates through their MyChart app. I mean, those things are happening. They're not waiting for the federal government to tell them to do it. They're doing it in response to what people want. So I think there are phone apps that you can do these things. There's other third-party softwares. I believe Brian uses TrueBridge. So the technology is catching up to use the data in each organization's EHR and billing system to better give price estimates. We also know of some of the really tight ACOs. Because of those arrangements, hospitals are able to provide even price quotes for the independent providers as part of that because of those types of things. So all of that is evolving, and it's not waiting for the federal government to tell them what to do. It's because it's the right thing to do. So, and I just want to add one other piece, because there's a lot of technology that's coming along that isn't even the bill. I mean, I'll bring up just one example, and this is the 270, 271 transaction. So in the weeds again, but basically what that is when a provider is sitting with a patient, they can send off a 270, which is an eligibility request to the patient's payer. And that shoots back what their eligibility is, where they are in their out-of-pocket, all those kinds of things. So as both payers and providers adopt these standards, those things can be built into the technology to give real-time type things, which coordinates the provider and the payer information. And why that's important is because, back when papers were done on who's responsible for what part of transparency, HFMA did a paper that had health plans, providers, they basically said that the source of transparency for all of the insured should come from the insurance company. Now, providers, when we acknowledge that, but said, but the reality is the providers are the one standing face to face with the patient. And so we need to be able to tie into what the payer has and in addition to the information we have, and combine those and be a liaison for the patient. And so these technologies, advancements in EHRs and those types of things, and leveraging that's happening now. And I think that's an important piece as we look to future rules and stuff, is to understand what the best practices are that are occurring today, because I think that's where some of these rules fall down. They're going off on their own path instead of seeing what the best practices are.
Cheryl, what is missing from these conversations? Not just this conversation, but transparency conversations in general. What advancements have we not yet made in transparency that you think we need to really move this forward?
Well, I think we're getting there on price transparency. We're not all the way to bright, for sure. The ultimate goal from my perspective would be to help employers and consumers understand what money will come out of their pocket. That's for price. The other missing component, though, is quality information. Many employers want to be able to pair both quality and cost, price, when structuring benefit plan designs for their employees. And that quality information needs to be about specialty care, and if possible, at the individual clinician level. We know that there's variation in that care, and we'd like to better understand that and marry that with the price information that we now also are understanding.
And just overall, I mean, what, so far have you seen is that correlation, if any, with price and quality? Can we say that higher price equals higher quality, or is that not accurate to say?
No, study after study shows the two are not correlated. And so you cannot infer by knowing the price that anything about the quality. Low priced providers are not providing poor quality care. In fact, it's oftentimes the opposite. But we need to know both. We can't infer one from the other.
So we are unfortunately quickly running out of time here, but I want to end it with a question that we'll have each panelist answer. We've talked a lot about what's happening, what more we want to see. What more can our policymakers do, though, to help move this forward? Price transparency. I think there's different definitions on what that means and what is the best way to advance transparency. But this idea of transparency overall is starting to gain bipartisan consensus. Brian Stevens, let's start with you. What more do you think policymakers can do to advance healthcare transparency?
Well, I appreciate policymakers' interest in the topic, kind of on behalf of consumers and citizens. But as has been said, I think by all of us before, I really think where we've seen more movement over this has been in healthcare, working specifically with businesses, because obviously businesses want to be able to control their healthcare expenses. We've seen that work really well here locally, not only from a pricing standpoint, but also from a convenience standpoint. Years ago, we implemented urgent care at the request of one of our local employers. We've done specific direct-to-employer agreements in the last 5 years that have been really successful. And so I look less to policymakers and more to, direct communication and relationship between healthcare and businesses to really move the needle.
Great. Dana, what more, if anything, can policymakers do to advance transparency?
Well, I think there's a couple things policymakers can do. I think they should ensure that the information that's being provided is objective and that it's, useful for consumers to use. I think they can lead by example. I think policymakers can use information to create policies, to monitor programs in our state, and really be, top users of this kind of information. And then I think the last thing they can do is they can, in certain situations, working with others in the healthcare ecosystem, create incentives for the use of this information and make sure that, we are using the information to meet the goals of Wisconsin, which I believe is, the highest quality of care at a reasonable cost.
Great. Cheryl, what do you think?
Well, I agree with the idea of having Wisconsin policymakers be users of the information and encouraging the state as a purchaser to use the information. I would also say, you know, we have WIO, which is the kind of premier data repository. We need to fund this adequately. And Wisconsin is the only state in the country that has an all-payer claims database that does not benefit from ongoing state funding.
In addition, Cheryl, some states do require participation in these type of databases. Do you think that's something Wisconsin policymakers should consider?
I think if a voluntary model falls short, yeah, we should be looking at a mandate.
Great. Brian Potter, what do you think, if anything, policymakers could do to advance transparency?
Well, again, I think they need to understand what's going on in best practices. So I think they can maybe help in providing clarity. I think they can do damage by adding noise and things. And again, when we see rules that make efforts go in areas that aren't as helpful, you know, I think that can be under the guise of just doing something. And I think we see that oftentimes. And again, I think, you know, so you have to get the people that sort of understand what's working, and then again, try to kind of foster that and promote that and incentivize that. So I think there can be clarity that the danger with kind of multiple efforts, and then you get policymakers who might not necessarily understand all the ins and outs and not work with those that are in the know, can actually kind of create some noise. So there's sort of a caution there, but there is a role for them.
Great. Dr. Bartholow, what do you think?
Two things. One is you have a preeminent database in WIO. I would celebrate and protect it. As Cheryl has said, number two, we have also a preeminent health literacy group in the Wisconsin Health Literacy, which is attached to Wisconsin Literacy. Let's make sure that the consumer understands what it is that they're asking for, what information that we're trying to provide for them. Let's let providers and the system be literate for the patient, not the other way around.
Great. Should we require your fellow insurers that aren't participating in WIO to participate in it?
I'm where Cheryl's at, that voluntary participation is really, really valuable. We're capable of doing this as a free market. Let's put our shoulder to this, please. If we can't, you know, it brings us to different questions, but let's see if the open market, if the free market can't actually provide transparency that is useful to all of our Wisconsin businesses.
Well, great. Thank you guys so much for a great and robust discussion. I think this could have gone on for a lot longer, but we're out of time. So thank you so much for a great discussion. Thanks to our generous sponsors for making this discussion possible. And thanks to all of you for tuning in today.